So hello and welcome to another video. My name is Dr. Lasker. I'm a consultant radiologist and doing this video on behalf of radiologyseminars.co.uk. And before I carry on, I just want to say a big thank you to everyone that did come up to the CT head course that we ran last Saturday. Ooh, it was a tough and long day, but we managed to get through unscathed, and I think everyone had a really good time. Some really great feedback. I think we've been tweeting some of it, as you'll be able to see on the Facebook page, just to have a bit of an idea about some of the how well it was received. And it's really amazing that we're going to be able to continue to keep doing that course, and we will be back on the 6th of February next year to do the CT head course again. So if you feel like you missed out and you do want to come along, then please feel free to go to the website. Bookings are now open for the February acute CT head course. Right, without much further ado, I'm going to make this a bit of a quick one because I do need to rush. So this is an acute abdomen, as always an acute abdomen, and you might have noticed that this particular acute abdomen looks slightly different from the other acute abdomens that we've been looking at over the last few weeks. Now when you look at this, where is the contrast? That aorta looks the same density as the liver that's over there and doesn't look too different from the musculature which is sitting over here. And as we come further down, you can't really see much in the way of the portal vein. Yes, you can see the portal vein which is sitting there, but what I mean by that is that they're almost identical densities. Coming further down, looking at the kidneys, you can't really see any of the structures within it itself. So what does this mean? This means that this is a non-contrast study. So now I'm showing you a non-contrast study. To be more specific, I am giving you a CT-KUB. A CT-KUB basically means a CT kidney, ureter and urinary bladder, and is a way to look for renal tract calculi. So that kind of gives you a clue as to what we could be looking for and why this patient has come in. They have come in with very specific symptoms of right iliac fossa pain, and it feels colicky, and that's why this patient has had this scan rather than any other kind of scan. Now I'm going to do my usual thing. We're going to scroll all the way down and scroll all the way up. And for those of you that know me well, let's identify the aorta. That's this big trunk thing going on down here. Its aorta is on the left, AOL, and therefore the IVC is going to be on the right, which is over here. And we're just going to scroll through. You know, some of you may be looking for that renal calculus. Is there renal calculus on this study? And as you come all the way down, have we seen one? I'm going to go all the way back up for you guys and just try and show you whether there is a calculus or not. So, where they said right side, let's concentrate on the right side. And then as you kind of scroll further down, you can see that there's this tubular structure that is just sitting over here, just there, that tiny little dot that's sitting in the middle of my magnifying glass. That is the ureter. If you keep your eyes on that, we should be able to see where there's any renal tract calculus. Now, if there was a calculus, we should be able to see that ureter really easily. The ureter is actually sitting right here in the middle of the screen, and as you follow it down, we can see it start veering towards the urinary bladder, and at no point have we seen any sort of radiopaque structure to suggest that there is a calculus. Secondary signs would be upstream hydroureter, and the ureter is actually of normal caliber, suggesting that this is not a ureteric calculus. And yes, they may have had a previously passed calculus, so we come up to the urinary bladder and make sure there's no evidence of fat stranding around the urinary bladder and around the kidney, and there isn't. So this is not going to be a pain caused secondary to a renal calculus. So what on earth is causing that pain? So what I try and do is, if the patient, or if someone says to me that this patient got right iliac fossa pain, what else could be causing right iliac fossa pain? That's right, the appendix could be causing right iliac fossa pain. So I've got to start thinking along those lines. What else could cause it? A hernia could cause that kind of pain as well. And then in a patient who's a female, they may have some sort of ovarian issue or something like that that can be causing these kind of pains as well. So let's go from the bottom, quite literally from the bottom, so just so that we are used to looking through the bowel. And for those of you that want to know how to do this, just feel free to go through some of my older videos and you'll be able to find out how you go about doing this. But you can see I'm following the bowel, and it kind of veers around this way, goes forward. You can see it's veering forward like this, and what you do, you just sort of scroll up and down and make sure that you can see the bowel connecting to something else, and that's the next part to go to. It can be a bit like snakes and ladders, where you end up following the wrong piece of bowel and end up where you started. Just try and keep doing it, you will get there in the end. This is now the splenic flexure, and we're coming across to the transverse colon, going right across. So we can see my mouse is just sitting there, and we're actually kind of dipping down and then straight across to this side. You can hear my mouse wheel going through, going round, and that's because that's actually how I like to follow the bowel. I take a little bit more slowly than I otherwise would with the other structures. And look, now we're at the hepatic flexure, and we're going to sort of work our way down. Maybe some of you've seen it, maybe some of you haven't, but as you come down, we can see that this is more ascending colon, and we're kind of, the ascending colon is now kind of veering up and going down again. It's a bit of a loopy one, this one. And look, now we're kind of coming across this way. It's all a bit confusing, but what's actually happened is that the cecal pole is actually quite high up within the right upper abdomen. So cecal pole, how do I know that's a cecal pole? Let's try and find the ileocecal valve, which is going to be around here. The ileocecal valve, we've got this sort of fat lip-like structure, and you can see that the terminal ileum is coming out of there. Can you see that? I'm going to just follow that. That's the terminal ileum over there. But as you come further down, you can start to see there's a little bit of inflammatory change going around here. Now look at the fat that's over here, and look at the fat that's over here. It looks a little bit strandy. So is there some sort of terminal ileitis? Is that what's going on? And actually you can see that this terminal ileum sort of goes through what looks like a hernia on the right lower abdomen. So they've got a bit of a small hernia, but actually the bowel itself doesn't look too bad. There's not much in the way of dilatation at any point on this terminal ileum or the distal ileum. So I'm not entirely convinced that this is the cause of the patient's problems. However, look at this tubular structure that is sitting next to it. This is where there's a lot of fat stranding, and as you come further up, you can see that this fat stranding is actually almost like a halo sitting around this particular tubular structure, and then it ends up joining around this area over here, which is actually the cecal pole. So we already identified the terminal ileum coming off this way, and coming off that is another tubular structure which is sitting here, which looks very fat indeed, is actually the appendix. Now those of you might be wondering, so hang on, what about this hernia? So they clearly had some surgery in the past, because you can see a clip there, and you can see a further few clips that are sitting over here. So they clearly had previous surgery, most likely to be a hernia repair, and actually this is not the cause of the trouble. The cause of the trouble is this very dilated, enlarged appearance to the appendix, and therefore this would be consistent with appendicitis. Important negatives would be that this patient has not got a perforation, they have not got a collection. This would be in keeping with a developing appendicitis. For those of you that do have hawk eyes, yes, there is a periumbilical hernia that is sitting right down the middle with a bit of intra-abdominal fat. That is not the cause of this patient's problems. The problem is the enlarged appendix, which has got some fat stranding around it that you can see over here. Sorry, it's a very quick one. I do need to run today. So hopefully that was useful. Thank you so much for tuning in. I will continue to do this as long as I have interesting scans for you. So hopefully this was interesting enough and made the cut. Thank you so much for all your comments. Keep contact with us, and please come along to our course. I think you might enjoy it. Anyway, have a good week and stay safe. Bye.